Good evening, all PSD fellows and members. Tonight, we start our third PSD Select focusing on diabetes basics and complications. Hope everyone will stay and follow our monthly events. Before we begin our first episodes, let's place ourselves in the presence of the Lord. Dear Almighty and ever-loving God, we glorify and thank you. You have showered us with so much blessings. Your presence continuously reminds us of your faithfulness and guidance. We humbly ask you to shower our speakers today of your greatest inspiration so that they may share the most of their knowledge, heart, and soul to their respective topic. May we absorb the invaluable knowledge and put into practice what we have learned today. We pray that you bless all the committee in charge, that they may be able to fulfill their tasks responsibly, that the objective they have set may all be achieved. Your infinite blessing would mean the success of this activity. May we be living witnesses of your genuine love through the enactment of the knowledge acquired through this activity. We ask this in the name of Jesus Christ, our Lord and Savior, with intercession of the Blessed Virgin Mary. Amen. Tonight, in your slides, we have shown to you the PSD mission, vision, as well as the objective. And recently, we have the PSD statement of purpose. So the purpose of PSD is to give persons with diabetes lives with qualities unaffected by the condition. This is their right more than a privilege. This passion sustains and empowers us to find meaning and fulfillment. The PSD, it is also to understand and accept that diabetes is a complex condition affecting an individual, the family, and community. Knowledge of its biomolecular cellular origins and understanding of its intervention are as important as mastering its psychosocial dynamics. So it is also its purpose to be a family of responsible persons bonded by one passion. Agreeing with this agreement will strengthen will strengthen our unity. Criticisms fuel our growth. Love fills our camaraderie. It is to be a source of inspiration that informs, guides, and correct one another in daily practice. We find happiness in sharing knowledge and experiences that improves patient lives. It is to support individuals and organizations with similar noble goals, acknowledging that we all live in one world and fighting diabetes together multiplies good outcomes with a fraction of the effort. Collaboration drives inspiration, motivation, and creativity. Lastly, it is to welcome the cure. When diabetes no longer exists, we will reincarnate with new passion and direction. Our vision we involve with time, but the family lives on. So this is the PSD Board of Director of 2021. So we are about to start the PSD Select 3. We know that it is the objective of this PSD Select. It is the objective of the board. We took time at this pandemic to touch our fellows and members to share series of lectures to be updated through their virtual meeting. And tonight, we have the third series ng PSD. We have Diabetes Basics and Complication. Its objective is to discuss the updates of pathophysiology and management of microvascular and macrovascular complications of diabetes, as well as to discuss the biochemistry of insulin action. So, next slide, please. So here is the program. So we have a pharmacy ME grant from Boehringer Ingelheim. Topic is patient adherence and hypertension treatment considerations, a step to prevent cardiovascular complications. We have a speaker, Dr. Orlando Bugarin. And by 6:30 to 7:15, we are proud and privileged to have a very nice speaker with the topic of preserved heart failure by Dr. Gilbert Belela. So now we have to start the Pharma CME grant by Boehringer Ingelheim.
Good day to all our colleagues who are joining us today. I'm Dr. Orlando Bugarin, and I'm tasked to discuss with you patient adherence and hypertension treatment considerations. Okay, so for today, okay, let me start by giving my disclosures. I speak for the following company and receive honorary from them. And as an outline for our discussion, for our lecture, we would like to define adherence, the prevalence of non-adherence to hypertension treatment, and third is impact of adherence to clinical outcomes. So in the treatment of our patients with hypertension, we'd like to determine the different stumbling blocks. And one of them is here today, we'll be discussing adherence as one factor. So let me define adherence first. No? It's a degree to which the person's behavior corresponds with the agreed recommendation from the healthcare provider. I'm sure you have experienced or encountered a lot of our patients that are having problems adhering to your recommendations or to your prescribed management for hypertension. However, we'd like to also define compliance. It is the extent to which the patient follows the recommendations of the prescriber. So we either use adherence and compliance, but for today we prefer to use adherence. Your non-adherence in healthcare results when a patient's behavior led to failure to initiate or continue care the provider has recommended. So yan, madalas natin problema among our patients would be probably having a lot of reasons or different reasons trying to comply or trying to adhere to our management. So there are a lot of studies that will give us an idea, okay, non-adherence to our recommendation or our drug therapy or our prescribed drug treatment for them. So these are the different studies and showing the number of population that they have studied. And shown here is the percentage of non-adherence among the different studies and the population that were studied in terms of blood pressure treatment. So you can see a very high percentage of non-adherence among the population studied by the different authors. So we all know that your adherence affects the outcome of our treating our patients. And so we look into the different factors that may be contributory to this. Okay, here is one study by Bromley, which studied 840 patients with hypertension on monotherapy. And then he has assessed the association of BP control and adherence. Okay, and as you can see, the blood pressure control is less for those patients with of course, lower adherence to the drug therapy. The more adherent or compliant the patient is, of course, shows a better BP control. With Masaglia, the study of Masaglia published in Circulation 2009, which involved 18,806 patients newly treated for hypertension who are cardiovascular diseases free, okay, evaluated association of your cardiovascular events and adherence. Okay, so it includes the review of medical administrative claims for with a follow-up of 6 years. So as the adherence is low, okay, the risk is really high. But for those with high adherence, no, or wherein there's coverage of drug therapy for most of the days, no, that were of treatment, there was really a higher risk reduction in terms of the possible, in terms of the consequences or the effect of having increased blood pressure. Okay, so or probably the risk of uh, uncontrolled blood pressure. In term for Corral et al., no, another study looking into adherence and CV outcomes. This time it involves 242,594 patients newly treated for hypertension. Okay, again, looking into those patients with high adherence or versus those having low adherence. Again, the risk reduction is higher among those patients who have better adherence to the drug therapy. Okay, those with those with longer duration of pills availability for them. Okay. With terms of coronary outcomes and cerebrovascular outcomes, it is also shown here in the study by Corral that really with better adherence, no, there is better risk reduction in terms of coronary outcome or cerebrovascular outcomes for our hypertensive patients. So we really now have the evidence or there's a concrete evidence that shows better adherence results to better outcome for our patient. The factors related to non-adherence, no, is shown here, no, as being really multifaceted. No, yeah, there are five dimensions that were considered: your social and economic, your healthcare system, condition related, patient related, or therapy related. And as you can see here, uh, we'd like to emphasize that maybe most of the reasons that you may encounter for social and economic, of course, is the medication cost. Okay, your healthcare system, maybe just the patient-provider relationship, but on the condition related is, yes, I think this is very familiar. Patients tend to be non-adherent to our treatment when there is no symptoms. No, they don't experience the symptoms, or there are absence of comorbidities. For therapy related, I guess with now with all the different diseases that may be present or illness that may be present in one patient, we also as physicians tend to increase the number of drugs that is needed to be taken by our patients. So there's complexity of the medication regimen. The duration of therapy, sometimes yun na, hindi natin napapansin, no? That the patient is under drug therapy for such a long time, or we might be having the physician inertia. And next is the actual or perceived side effects. Minsan, we have seen this, no? Or patients would tend to believe their neighbors rather than the doctors in terms of the side effect of the drug. Next is the patient relation, a related factor, no? Disease knowledge, the perceived risk, and motivation and confidence. So these are the different factors that may really increase non-adherence of our patient to our treatment regimen. And I guess we are all aware of this, but unconsciously or subconsciously, uh, nawawala sa ano natin sa ating day-to-day practice, no? As we see patients in and out of our clinics or in the hospitals, we tend to be on the routine way of managing our patients and tend to forget the different factors that may result in adherence of our patient. So, how do we improve medication adherence in our patients with cardiovascular disease? So here's a systematic review and some recommendations for us to improve our medication adherence. So there are three distinct interventions as per Fuller RH and al. Okay, number one is short message service. No? So they recommend, so maybe by texting or by giving reminders, some of the services that the hospital or the clinics can offer for our individual patients. Community health worker-based intervention is another intervention that was recommended. I think this was very particular for our TB patients, but I'm not sure with our patients with hypertension if this is being done in the community. And the third one, which I think is very popular right now, the most common way of trying to increase adherence among our patients is the fixed dose combination pill. And let's go through it and let's see how this fixed dose combination pill really improve adherence among our patients. Your 2018 ESC/ESH hypertension guideline have shown in terms of detecting poor adherence to drug therapy, uh, there's really a poor BP control when the patient is non-adherent to our treatment regimen. And one factor that they have seen to improve blood pressure control is using a single pill combination treatment strategy. Okay, they prefer the use of two drug combination therapy for the initial treatment of most people with hypertension. Before they have seen this, but as a separate pill. But now with the technology, with science, they were with a combination of two class of drugs in a single pill. It has improved compliance or adherence among our patients with hypertension. So we now have what we call the single pill combination therapy for most of our hypertensive patients. Okay. Interventions that may improve drug adherence in hypertension, as mentioned in terms of decision level. A, of course, explaining the possible risks, the possible complications, and the way to approach the illness or the disease or the hypertension in our patients, and giving the benefit of the drug treatment that we're offering. We try to empower our patients. We ask for feedbacks, no? And of course, we look into the different barriers that may cause non-adherence to our patient. Patient level, in terms of intervention, of course, we encourage them to monitor their blood pressure. We may use some reminders, instructions, or motivations. We ask for family support. We've been lecturing about this, not just for our patients who have diabetes, but also for our patients with hypertension. Health system level, of course, the support system, the pill health coverage, okay, the reimbursements for our drug, and now we have the different healthcare centers providing free of charge, some of the different class of antihypertensive drugs and affording accessibility to the drugs for our different patients. Of course, the drug therapy at the drug therapy level, we want a simplification of drug regimen, and here comes the single pill combination therapy. So the introduction of this management or this strategy really offered a better adherence for our patient. The number of medication and adherence, to elucidate or to emphasize here in this study by Gupta et al. It shows that the more drugs that we prescribe to our patients, the number of pill that they have to take, the more that we have those written in our prescription, it increases the possibility of non-adherence of our patient to that regimen. They are, yun nga, sabi nga ng iba, nagsasawa na po sila sa dami ng gamot na iniinom nila. So that's one factor. And with that non-adherence of our patient, as we can see here, the risk, of having the different complications, as mentioned, if the blood pressure is not controlled. But here in the study by C, et al., no, the current published the current medical research and opinion, again showing the adherence to single pill versus those taking double pill and triple pill. Okay, as there is more there was more adherence seen, no, in patients who are given single pill combination therapy versus those that are given double pill or triple pill, no? And for those with less the adherence, for those that yung availability of the drugs, I mean uh, days covered, or the percentage of days patient had pills available, no, as for single pill, double pill, and triple pill, if it is less than 50%, no, mas tumataas naman kapag they have the triple pill. Okay, so siguro when there's the choice for the drug that has to be prioritized to be taken doon, so nagiging factor na rin yun para sa mga patients natin. But if the drug is set as uh, a single pill combination, you use the single pill combination strategies, it provides or it renders more adherence for our patient. So again, comparing your drug combination, no, your single pill versus your fixed dose combination, here in this study by Gupta, it showing or a meta-analysis of the different studies, no, it has shown that your fixed dose combination therapy is favored over your single pill. I mean, your individual pill strategy. So, as a recommendation by the ACC for their hypertension guideline in 2017, the initiation of antihypertensive drug therapy with two first-line agents of different classes, either as separate agents or in a fixed dose combination, it is recommended in adults with blood pressure more than 140 over 90 and an average BP more than 20 over 10 millimeters mercury above their BP target, got a class 1 recommendation. No? So either two first-line agents or of different classes. But as mentioned, okay, your single pill combination is the preferred strategy if ever we do give two antihypertensive drugs for our hypertensive patients. This one got a class 1 recommendations. Of course, the exceptions are for frail, older patients and those at low risk and with grade 1 hypertension. Your ISH guidelines or the algorithm that was shown or published in 2020. Okay, the drug treatment strategy was first dual low dose combination, then titrate it up. Okay, again, ideally single pill combination therapy is recommended. So either you start up low dose, then titrate it up to its full dose combination. If it does not still control the blood pressure, we go up to titrating it to a triple combination. And if still uncontrolled, we proceed with treating it as a resistant hypertension. So we add up our diuretic spironolactone or other drug. So in terms of the 2020 ISH recommendations, the adherence to antihypertensive therapy. So they try to evaluate the adherence at each visit, and they consider the following strategies to improve medication adherence. They recommend reducing polypharmacy. So the use of single combination strategy help. Of course, one daily dosing over multiple times per day dosing is, if possible, is preferred. Is preferred. No? Next is linking adherence behavior with daily habits. Providing adherence feedback to patients when they visit us in their clinic, we try to ask them if they can take the medicines as scheduled or as prescribed, or are they encountering any problems. And of course, the feedback of whether their blood pressure is controlled when they do their home BP monitoring. The reminders and packaging of medications, I'm not sure if this is practice here in our country, no? But I think most of our patients would really rely on our instructions as we send them home with our prescriptions. Empowerment-based counseling. I think the only chance we can do this is really as we face, as we see them, as they consult us in our clinic. Of course, right now with the technology is the electronic adherence aids, no, such as mobile phones or short messages services. As mentioned, this was one of the recommendations to improve adherence. No, we try to remind our patients through the different way technology, no, try to reach out to them. And lastly, multidisciplinary healthcare team approach is one way to improve medication adherence. So one of the drugs that now is very common in our armamentarium in treating our patients with hypertension is the ARB telmisartan. And just to emphasize now its advantage over the other ARBs, here we can see that your telmisartan have the longest plasma half-life, rendering it sustained effect for our patients. And I think one of the advantage that is being really emphasized by the company is that it has the 20 hours or more. No? I think it's more than 20 hours. It can reach up to 24 hours of sustained efficacy. Next is since it has the highest receptor affinity compared to the other ARBs, and it is most lipophilic, rendering it to have a high tissue penetration and therefore better efficacy for this ARB compared to the others. The throw to peak ratio provides another advantage for telmisartan, as mentioned, with its long half-life, so rendering it, sustaining its efficacy for 24 hours, and thereby you can only simplify your drug regimen for this ARB, which is once daily dosing. Okay, so that's one advantage again of this ARB. And that as to the pharmacokinetic profile, again, to emphasize your telmisartan compared to your other ARB, your terminal half-life is 24 hours, and the throat to peak ratio is 80 to 100%. With its long duration effect, okay, uh, the BP reduction after active doses versus valsartan. In this study, it is shown here in this slide that your telmisartan offers a better and sustained control of your blood pressure over the 24-hour period versus your valsartan 116 milligram. And its combination as a single pill combination drug together with your amlodipine, adding your telmisartan or adding amlodipine to telmisartan provides additional BP lowering effect. So there's synergy between the two drugs, offering better control of blood pressure among our hypertensive patients. As mentioned, there's a synergistic effect. They have synergies of counter regulation. Your ARB and your dihydropyridine calcium channel blocker, and in this case, your amlodipine. So they complement each other. As for your CCBs, causing arterial dilatation, peripheral edema, effective in low renin patients, reduces cardiac ischemia. This is complemented by your ARB as having the effect of venodilatation, attenuates your peripheral edema, effective in high renin patients, and has no effect on cardiac ischemia. As to the other side, your ARB causes RAS blockade and has benefits for our CHF and renal patients. It is complemented naman, on the other side by your DHCCB as having no RAS activation, however, with no renal or CHF benefits for your CCB. I think one of the prominent synergistic effect that these two drugs has when given to our patients is that the ERB counters the most para pinaka-concrete side effect ng amlodipine, which is your peripheral edema. So less occurrence of your peripheral edema when your amlodipine CCB is combined with ARB telmisartan. So together as a single pill combination drug, this telmisartan plus amlodipine has a safety and tolerability profile similar to your placebo. Okay, So as mentioned, commonly we encounter edema among our patients, bipedal edema among our patients with amlodipine, but together with telmisartan, there's less occurrence of this side effect. So as a summary, I'm sure we have seen this, that in our clinics, among our patients, non-adherence is common. Drivers for non-adherence are multifactorial. It is associated with poor clinical outcomes and increased your healthcare costs. Improving your adherence will require a multifaceted approach. Studies on telmisartan show that through its unique pharmacology, it provides 24-hour PP control. And together with amlodipine, your telmisartan fixed dose combination provides additional BP lowering therapy and better patient adherence. And this is, I think, marketed as Twin Stack. So with that, I'd like to say thank you for your attention.
Thank you. Thank you, Dr. Orlando Bogarin, for giving us the cause of non-adherence and how to improve our in these cases, or what improve our approach with this case. So thank you so much, Boehringer Ingelheim, to be our CME, to give PSD this CME grant. So now tonight, we'll proceed with the diabetes complications. Itong topic na ito, the preserved heart failure, we choose this topic kasi nakita namin, we have a lot of patients na nakikita natin na reserve ang heart failure. But little we heard about this. Ang lagi tayong bombarded tayo ng mga lectures ng mga reduced heart failure. So everybody is excited with this lecture because we are to be enlightened with our topic for tonight na reserve heart failure. We are proud and privileged to have with us the President of the Philippine Heart Association, the Director of Education, Training, and Research at Philippine Heart Center, as well as the Secretary of the Philippine Society of Hypertension. Our guest for tonight is both a fellow of Philippine College of Physicians and Philippine College of Cardiology. Internationally, he is an associate fellow of the American College of Cardiology, certified hypertension specialist, a certified facilitator, Franklin Covey Center for Leadership and Change, Incorporated. So tonight, I'm very proud to present to you Dr. Gilbert Velela. Let's have a round of applause.
Magandang gabi po, Sabado ng gabi. It's so nice to be here. Kinoconsider ko pong karangalan ng magsalita sa mga kaibigan. Kaya ito po ay isang pagkakataon na hindi ko talaga papalampasin. Magandang gabi sa 71,000 na attendees natin ngayong gabing ito. Salamat at I hope I give justice to this lecture because it's a very, very nice topic in fact. Salamat Marcy sa pag-imbita and salamat Elwin sa pag-imbita rin. At I hope I can give you what I have studied a lot para sa inyo. Can I share my screen now?
Okay po.
Salamat. Naririnig niyo ako?
Opo, very clear.
Salamat.
Yes, sir. Thank you.
Thank you. Nakikita yung slides ko?
Yes, sir.
Oh, yes, sir.
Okay, thank you very much. So, HFpEF. Siyempre, ang kasunod dyan, hindi hooray. Kasi nakakatakot ang HFpEF. Heart failure with preserved ejection fraction. It is really a growing menace all over the world, especially here in the Philippines. Sa buong mundo, lalo sa US. Sa US, dadami ng 46% ang mga pasyenteng may heart failure, whether it's reduced ejection fraction or preserved ejection fraction. Bakit? Kasi gumagaling yung management natin ngayon sa heart failure. Kaya dumadami nakakaligtas ng mas mahabang panahon pa. Bukod doon, because tumatanda ang population, as we all know, the elderly is more of a high risk na mag-develop ng heart failure, whether it's reduced or preserved. Pero ang nakakalungkot doon, Marcy and Elvin and the rest of the guys here, alam nyo, ang nakakalungkot talaga, sobrang, minsan nadidepress din ako eh. 50% ng mga taong na ginagamot natin na may heart failure, patay sila in 5 years. So kung may 10 kang pasyente may heart failure, 5 lang makaka-survive beyond 5 years. And worst of all, 3 lang makaka-survive in 10 years. Kaya ang hirap-hirap makipag-deal sa mga pasyenteng ganito. Kasi hindi lang talaga bibigyan mo ng siyensya, bibigyan mo ng puso mo talaga. Dito sa Pilipinas, 1.6% ng mga pasyenteng na-admit dito sa ating mga ospital na under sa PhilHealth. No? Ito ay survey ito ng PhilHealth, yung kumukuha ng refunds sa PhilHealth. Nakita nila na 16 cases of heart failure for every 1,000 admitted sa ating mga ospital. Pero ang pansin nila, mas mataas ang mortality rate natin kaysa sa Western and other Asia-Pacific countries. So in the beginning, ito yung definition ng heart failure. Alam nyo na ito. Siyempre, ano pa lang tayo, intern pa lang yata o clerk, sinasabi na sa atin to. Heart failure is the inability to provide adequate cardiac output to the body at rest or with exertion, or to do so only in the setting of elevated cardiac filling pressure. So, ibig sabihin yan, alam nyo na ibig sabihin yan. Ibig sabihin, pag tumakbo ka, hindi siya makasupport ng more blood to your feet. Kaya it's heart failure. Kaya mas hingal ka. Makakabigay lang siya ng sufficient blood supply kung tataasan daw niya yung cardiac filling. Ibig sabihin, yung bang Franklin Starling's law, di ba? Pag meron kang ganitong kahaba na muscle, sinistretch mo ng mas malaking ganyan, mas malaki yung contraction. So they are aiming at improving cardiac output by increasing the stretch or the preload. Pero pag tinaasan mo yung cardiac filling pressures para ma-stretch yung myocardium, tataas ang pressure sa left ventricle. Kaya hihingalin lalo ang pasyente. Mamaya, kikwento ko sa inyo paano hihingalin ng pasyente. Clinically, heart failure is a clinical syndrome characterized by breathlessness, fatigue, and edema caused by an abnormality of the heart. So siyempre, ang importante dyan, yung operative word dyan is caused by an abnormality of the heart, meaning either it's structural defect, like valve disease or probably left ventricular hypertrophy, or functional defect. Okay. Tapos, kasi maraming cause ng breathlessness. Di ba? Maraming cause ng fatigue. Maraming cause ng edema. Baka kaya naman namamala siya, meron kidney disease. So, dapat meron talagang specification caused by an abnormality of the heart, either structural or functional. Ang history naman ng heart failure with preserved ejection fraction or HFpEF, ito yung unang-unang na-coin noong 1984 na hindi naman na-discover but unang ni-recognize as a clinical syndrome noong 1984 ni Anne Hamilton Doherty. Ang tawag niya noon dito is congestive heart failure with normal systolic function. So normal, kasi ang kanyang ejection fraction is normal. Pero nagko-congest siya, nagtataka sila, bakit ganon? Nagkaka-fluid ng lungs pero normal ang systolic ejection fraction. So hindi lang maintindihan, kaya sabi nila, in the report nila noong 1984. Ngayon, tinanggal na yung salitang congestive. Kasi maraming pasyenteng may symptoms ng heart failure pero hindi sila congested. Kaya tinawag na ng heart failure with preserved ejection fraction. The following year, in 1985, si Saufer naman, ginamit niya yung salitang intact systolic LV function. So, ibig sabihin, maganda pang contraction. Pero nagko-congest yung pasyente. Kaya nireport nila ito. Ang problema nating lahat, pareho sila ng signs and symptoms ng HFrEF, ng reduced ejection fraction. Pareho sila may edema, orthopnea, PND, rest dyspnea. No? Kaya lang, ang difference na nila, mas kakaunti ang S3, yung tigidig. Kasi diba dapat tig, dapat gano'n labdab. Labdab. Pero pag meron kang heart failure, labadab, 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 ganoon ang tunog nun. Pag pinakinggan mo talaga, ganoon ang tunog. Tapos mas malaki lang ang puso sa X-ray or sa echo o sa ECG ng pasyenteng merong HFrEF than HFpEF. But definitely, parehong-pareho sila. So, ang hirap sabihin ko, which one is which? Lalo na pag nag-uumpisa pa lang pag initial visit ng pasyente. Kaya ngayong taong ito, in 2021, gumawa na sila ng bagong definition ng heart failure. So maswerte tayo, sakto yung ating lecture, magagamit natin itong universal definition of heart failure. Lahat ng heart failure bodies and guideline makers, ito na ang ginagamit. So ano daw ang heart failure? Ang heart failure is isang syndrome composed of symptoms and signs ng heart failure caused by structural or functional cardiac abnormality. So again, inulit lang nila yung sinabi ng unang panahon. Ito ay symptoms and signs pero galing sa structural or functional cardiac abnormality. Tulad ng sinabi ko sa inyo noon, ang chronic kidney disease or diabetes, no, without other causes can have these symptoms and signs. Pero ang importante yan yung may corroboration siya. So corroborated by at least one of the following. First, mataas dapat ang NT-proBNP, ang kanyang BNP. And second, pag nakinig ka sa lungs, may crackles o may rals. Tapos pag tinignan mo yung extremities niya, may edema, may manas. So dapat ganun. Ulit, signs and symptoms ng heart failure na merong mataas ang BNP at may rals sa lungs at may manas na galing sa LVH or valvular heart disease or whatever na nakita mo, which is structural or functional cardiac abnormality. So ito yung symptoms. No? Gusto ko lang sabihin yung typical symptoms ng heart failure na nirecognize itong 2021 universal definition. Breathlessness, orthopnea, PND, so forth and so on. Fatigue, ankle swelling. Ito naman yung signs. Elevated JVP, S3, S4, cardiomegaly, chain strokes, respiration sa advanced heart failure. So yun ang signs. Ito. So pag meron kang ganung signs, ang next na gagawin mo pag sa outpatient or inpatient, mag-request ka ng natriuretic peptide. It's either BNP or NT-proBNP. Ito sa Pilipinas, mas maraming NT-proBNP siya yung ginagamit. So kapag may heart failure signs and symptoms ka, nag-request ka ng NT-proBNP, dapat more than 125 kung outpatient, kung sa clinic mo nakita. Pero pag in-hospital, more than 300. So pag may signs and symptoms plus more than 125 or more than 300, that spells heart failure. Tapos, gusto lang sabihin natin lahat ito. Ang heart failure ay may stage, 4 na stage. Bakit nila ginilagyan ng stage? Para malaman natin na ang heart failure pala is preventable. See? Kaya nakakalungkot talaga. I mean, ako personally, nalulungkot ako pag may pasyente akong nadadiagnose sa heart failure kasi talagang yung bang alam ko na in 5 years ang pangit ng kanyang prognosis. Pero hindi mo na masabi sa kanya. Lalo na pag matigas pa ulo, parang gusto mong putusan. Well, anyway, so ang importante is ma-prevent natin na magkaroon siya ng symptomatic heart failure. Kasi from then, talagang delikado na. So ang stage A, ang pasyente daw is high risk pa lang. Meron siyang mga condition o comorbidities na magpipredispose sa kanya to develop heart failure like hypertension, diabetes, smoking, obesity, and so forth and so on. Stage A yon. So, yung mga inaalagaan yung pasyente, diabetes siya. Kunwari, 35 years old, 40 years old, diabetes. And diabetes, heart failure na yan. So, dapat remember, yung pasyente yan, mag-heart failure yan. I bet you, alagaan nyo ng maigi. Kung sa mga pasyente hindi nagpapakontrol ng blood sugar nila, so lumalala, mataas yung HbA1c, they develop a worst stage, which is the stage B, structural heart disorder without symptoms. So itong malaki na yung puso nila, hypokinesia na sa echo. Tapos, malaki na ang puso kung minsan, yung dilated ang heart, pero wala siyang simptomas. Kaya nga, stage B siya. So pag ginamit mo yung New York Heart Association classification ng symptoms, ng degree ng disability na produce ng heart failure, which is the NIHA classes, class 1 pa lang siya without limitation of normal physical activity. Pag hindi pa rin nakinig sa ating pasyente, hindi na control ng risk factors, ang comorbidities niya, papasok na siya sa stage C. Ito na yung merong symptoms, no? Yung kanya mga structural defects, hindi na nakapag-compensate, hindi na nakayanan ng puso, nagkaroon na siya ng symptoms. So, ang stage C, usually dyan nagsisimula yung NIHA class 2. And then, NIHA class 3 kapag hindi na-control. Pag matigas ang ulo, nagsasaw pa sa patis, kumain sa Japanese restaurant, nagsasaw ng kikoman and so forth and so on, nagkare-kare, nagbagoong, ayan na, stage 3. And in the end, talagang yung puso niya para yung medyas ng lalaki, yung luma, yung ayaw nang kumapit sa binti, nakakulumpo na lang sa ankles. Ayun, advanced heart disease. Systolic usually ang ending, hindi diastolic. Pero yung mga pasyente may systolic dysfunction, yung HFrEF, have concomitant HFpEF. Bukod sa hinang-hina at dilated na yung puso niya, matigas pa rin ang kanyang puso at the same time. So, ito ngayon ang universal definition of heart failure. HFrEF, HFmrF, HFpEF, tsaka HF-improve EF. Okay. So pag ang normal talaga na ejection fraction, ang normal ejection fraction is around 60 to 70%. Kasi yung isang myocardial fiber, isang myocardial pag nag-contract siya mag-isa, 20% ang kayang i-contract. Pero together, as part of the left ventricle, they can contract larger. Mas malakas sila mag-contract. And usually 60%. Pero yung standard deviation, no, hanggang 55. Kaya ang sabi ng guidelines, 55 or 57, pataas ang normal ejection fraction. So, kapag ikaw ang ejection fraction mo is less than 40%, HFrEF ka, reduced ejection fraction. Pag ang ejection fraction mo is between 41 to 49, mid-range ka, or mildly reduced ejection fraction. So mildly reduced ejection fraction. Guessing work pa yung MRF na yan. And then pag ang ejection fraction mo is more than 50%, HFpEF, preserved ejection fraction. So parang normal ka. So pag more than 50%, pwede siyang mag 55, 56, 57. And yet you have symptoms of heart failure. So HFpEF yun. Pero pag ang pasyente mo na ginagamot, dati 40% o 30% yung injection fraction, yung galing mong magdoktor sa kanya, na-improve mo after 6 months, naging 50% na yung kanyang injection fraction, na-improve mo o from 30, nagawa mong 40%, then ang tawag doon, heart failure with improved ejection fraction. So bakit nila kailangan gawin yan? Para nagkikwentuhan tayo. Nagkakaintindihan tayo ang ibig nating sabihin. At saka, bawat stage niyan may sari-sariling katapat para na matching type. May katapat siyang treatment. Ito yung sinasabi ko sa inyo kanina. Combined survival rates of people with heart failure over time. At 5 years, 5 years. Ayan, kita yung pointer ko. At 5 years, mga 50 to 55% ang survival rate. Pero in 10 years, 30% na lang ang buhay. No? Kung may 10 ka, 3 na lang ang buhay, 7 namatay. Madaling sabihin niya, pero isipin niyong maigi. Kung yung taong yan na may heart failure, kamag-anak mo, o mahal na mahal mo sa buhay, o magulang mo, o wag naman sanang ipahintulot ng Panginoon ni spouse mo. Di ba kabaliw-baliw yan? Kaya nga, kailangan pag-usapan natin yan. Paano natin ito maaayos? Ngayon, mas maganda na ang kinabukasan ng HFrEF kaysa sa HFpEF, no? Dahil sa madaming bagong innovations into treatment, kita nyo, gumaganda na yung Kaplan-Meier curve, no? Itong latest, yung black, tumataas na. Pero tingnan nyo yung Kaplan-Meier curve ng HFpEF, magkakadikit pa rin yung guhit. Bakit? We are missing a lot. And what are we missing a lot? The pathophysiology, the definition really of preserved ejection fraction heart failure. So HFpEF is not HFrEF. Sinasabi ko yan sa lahat ng kausap ko kasi ang ginagawa nila, yung treatment ng HFpEF ay pareho ng treatment ng HFrEF, which is actually mali. Kasi magkaiba ang kanilang hemodynamics at ang kanilang pathophysiology. Tingnan nyo lang ito. Elvin, tingnan mo itong picture ng HFrEF. At tingnan mo itong picture ng HFpEF, itong hypertrophy. Ang laki ng difference. So paano sila magkakapareho ng gamot? Ang problema sa HFrEF, sa reduced ejection fraction, tingnan yung myocardium, manipis na at korteng basketball na yung puso. Sa totoo lang, ang puso natin dapat korteng rugby football. Korteng football dapat oblong. Pero para mas madali siyang mag-contract. Pero kapag korteng basketball, pag nabibilog na ang puso mo, mas mahirap na i-contract. Kasi ang taas-taas ng pressure dyan sa gitna, dyan sa loob ng lumen. Actually, ang main difference is dito sa HFrEF na to, dito sa picture na to, na manipis na myocardium na malaki, siya ang dahilan ng lahat ng mga nangyayari sa pasyente. Siya ang dahilan ng release ng sympathetic system and the inhibition of the parasympathetic system, release ng renin-angiotensin-aldosterone system, release ng lahat ng corticosteroids, lahat ng stress hormones, lahat ng everything, pati yung catabolism na nangyayari sa isang pasyente may HFrEF dahil sa kanyang reduced ejection fraction. Siya ang dahilan kung bakit mayroong cardiorenal syndrome. Kasi hindi nakakaabot yung cardiac output sa kidneys. Kaya yung kidneys mo is ischemic, kaya ang gagawin niya mag-inarte rin sa kidneys. Thereby, ano bang tawag doon? Yung cycle na nakasasama, no? Vicious cycle. So siya ang dahilan. Ang main difference ng HFpEF, dito sa picture sa gitna, siya, yung LV mo, yung puso mo, siya ay biktima, hindi siya ang cause. Kaya siya lumaki kasi merong hypertension yung pasyente. Kaya siya malaki kasi may obese yung pasyente. Kaya siya malaki kasi may chronic kidney disease yung pasyente. Kaya siya malaki kasi may diabetes yung pasyente. So, sa HFpEF, kaya siya ganyan, siya ay biktima. Kaya siya hypertrophied. Alright? So, preserved systolic ejection fraction, wala siyang dilatation, concentric left ventricular remodeling, as meron siyang diastolic left ventricular dysfunction. Unlike the other one, which is systolic na dilated, tapos meron din siyang systolic dysfunction alongside with left ventricular diastolic dysfunction as well. So see, sa HFpEF, siya ay biktima. Sa HFrEF, siya ang dahilan. Ito ang mga antecedent o comorbid diseases na identified na kapag meron ka nito, you're in danger or you're in stage A. Yan, kapag ang pasyente mo ay may ganito, stage A heart failure na ang tawag dyan. Pag meron siyang hypertension, meron siyang diabetes or insulin resistance, pag siya ay overweight or obese, o meron siyang CAD, on taas ang kanyang cholesterol, which predisposed the guy to have coronary stenosis, or aging, meaning above 65 years old, or anemic, o meron siyang chronic kidney disease. Kasi ang chronic kidney disease, it's an afterload problem para sa heart. No? It's an afterload problem sa heart. Hindi increase yung resistance to the ejection of blood to the periphery kasi ang taas ng pressure pag meron chronic kidney disease. This antecedent or comorbid diseases gives the heart a large hemodynamic load and a metabolic load at the same time, which stimulates sympathetic release and the inhibition of the parasympathetic nervous system. Buro mo, bibilis ng sobra ang puso, ang tibak ng puso mo. Bakit? Nagko-compensate siya eh. Kakunting ang cardiac output, kaya nagko-compensate siya. Tapos ang nangyayari, si parasympathetic dapat magpe-preno sa kanya, magbe-brake sa kanya, wini-withdraw ng katawan mo. Kaya wala siyang pambalanse. Tapos of course, there's an imbalance of the renin-angiotensin-aldosterone system. Yung napasobra sila ng release, napasobra ng compensatory mechanism. At the same time, habang nangyayari yan, you know that these things, no, all these comorbid diseases are pro-inflammatory and pro-fibrotic. They release a lot of interleukin-1, interleukin-1 beta hanggang sa interleukin-6, tumor necrosis factor alpha, yung SD2, which is along with pentraxin and galectin and TIMP1. Ito yung mga pro-fibrotic eh. Pro-fibrotic, pag marami ganyan, it produces more fibrosis. Lalo na yung mga diabetics, maraming galectin ng mga pasyenteng may diabetes. Kaya talagang they produce a lot of pro-fibrotic molecules. So they also release a lot of fibroblasts, upregulation ng fibroblasts. Kaya tuloy, sa buong cardiocirculatory system mo, there's a lot of collagen deposition. Kaya ang titigas yung yung arteries mo. And at the same time, titigas din ang left ventricle mo. Ako, ang general idea ko, ang left ventricle is the largest blood vessel of our body. Kasi kadugtong yan eh. Kadugtong yan ng aorta, arteries, smaller arteries, arterioles, capillaries, veins, and magkakadugtong yung isang haba lang yan. Pag nilagyan mo ng pampatigas like collagen and fiber, diba? Ang collagen, it does not distend, unlike the myocardium or elastin. It distensible ang elastin. Pero pag nananalo ang collagen, tumitigas ang blood vessel at mahihirapan na mag-pump ang blood ng enough blood for circulation doon sa matigas na arterial system. Kaya lalaki din siya at titigas din siya. And at the same time, itong comorbid diseases na ito are pro-inflammatory, which will cause endothelial dysfunction through an excess and overflow of oxidative stress, causing vascular endothelial dysfunction. Kapag meron kang endothelial dysfunction, kahit walang stenosis ang iyong blood vessel wall, ang hirap ng flow, no? Kahit walang bara, mahirap ang flow. Bakit? Kasi natanggal. There's a rapid decline of nitric oxide, and kabaliktaran nun, there's an increase, a release of endothelin, which constricts the blood vessel wall. And at the same time, itong mga oxidative stress the free radicals, they attack the cardiomyocytes, causing it to hypertrophy and causing phosphorylation of titin. Mamaya ipapakita ko siya ano mangyayari pag nag-phosphorylate sila ng titin. So kapag makapal ang puso mo, and at the same time matigas ang puso mo, what do you call that? Diastolic dysfunction. Kaya yun ang chief hemodynamic drive ng HFpEF. Ito yung itsura, no? This is sa taas is the normal heart. Sa baba is the heart with HFpEF. As you can see, hypertrophy ang LV. So there's cardiomyocyte hypertrophy, and there's a lot of fibers, no? Para bang ang daming abaka sa puso mo. Kaya di ba, ang abaka, hindi naman siya nagko-contract eh. Hindi na siya nagdadilate. Kaya ang tigas ng puso mo. Anong mangyayari pag matigas ang puso ng isang tao? Remember, if you have a heart like this, bago naman niya mag-contract, hindi naman siya ganyan eh. Bago siya mag-contract ng ganyan, dadilate muna, tapos see, that's diastolic dysfunction. That's diastole. Yung ganyan muna. Then, wag lalaki. So, ganun siya, parang bumibelo. Pag maraming fiber at collagen ng puso mo, hindi na siya maka-diastole enlargement. So, ang tataas ang pressure dyan sa LV. Pag mataas ang pressure sa left ventricle mo, during diastole, nakabukas yung mitral valve. So, the left ventricle and the left atrium behaves like a single chamber. Kaya yung mataas na pressure sa LV, natatransmit sa LA. Diba? Sino man nagde-drain sa left atrium? Pulmonary veins. Sino nagde-drain sa pulmonary veins? The pulmonary capillaries. Kaya ano mangyayari? So yung pressure from the LV will be directly transmitted to the pulmonary capillaries. Kaya yung pulmonary capillary wedge pressure will increase. Ano mangyayari? transudation ng fluid. Kaya yung pasyente mo, hihinga-hinga siya, hindi siya makahinga kasi ang tigas ng lungs niya kasi congested ang lungs. Yun ang dahilan kung bakit sila nag-shortness of breath and easy fatigability because of those things. Bukod doon, look at the position of titin. No? Ang titin ay siya yung molecular spring ng sarcomere. Siya nagdidikit-dikit sa lahat ng striated muscles sa ating katawan. Si titin ang nagdidikit-dikit across sarcomeres. Unfortunately, pag na-phosphorylate siya, nag-abnormal siya, tumitigas siya, nakakontract. Kaya ano mangyayari sa cardiomyocyte mo? Yung magiging tense masyado. Naka-tense siya, naka-constrict, naka-tone. So, hindi siya tumigas siya, hindi siya mag-diastole, hindi siya elastic. Tataas yung pressure doon. So, bukod sa increased fibrosis, umigsi pa, na-phosphorylate pa yung titin mo, naging toned pa yung cardiomyocytes mo, kaya ang tigas-tigas ng puso, thereby transmitting the subsequent increase in the left ventricular and diastolic pressure to the pulmonary capillaries, congesting your lungs. So, this is a myth. The myth is we understand the etiology of HFpEF. Actually, we do not. We are just presuming. Marami pa po na aaralin tayong lahat. But at this point in time, in 2021, ano bang date yan? June 17 ba ngayon? July 3 pala. So, July 3. Pasensya na kayo. Alam niyo, araw-araw ako nag-lecture. Disoriented na ako. You know? So, July 3, 2021, ang alam lang natin, diastolic dysfunction ng primary hemodynamic ng HFpEF. Diastolic dysfunction, matigas ang puso. Ang iisip nila, theories, baka there's a dysfunctional calcium handling, abnormalities in spring-like titin protein, kasi sabi ganina, there's an increased extracellular fibrosis, reduced ventricular compliance, and shift in the pressure-volume relationship. Ang ibig sabihin nun, konting pressure, konting volume lang, taas agad ang pressure kasi ang tigas ng LV mo. Kaya kahit konti lang nilalaman ng iyong LV during diastole, ang taas agad ng pressure kaya hirap na yung puso mo. So these are the known HFpEF pathophysiology. Unang-una nga, sabi natin, meron siyang diastolic dysfunction. Second, impaired vasodilatory reserve. Ibig sabihin, during times of needs periphery, yung metabolic need ng muscles mo when you exercise, dapat nagdadilate ang mga arterioles and smaller arteries supplying blood to the periphery. Pero you lose that. In HFpEF, you lose that. There's impaired vasodilatory reserve. Third, there's impaired systolic reserve. Siyempre, when you exercise and you have HFpEF, kailangan when push comes to shove, mga pao ang katawan mo, more supply to supply the needs. Kasi tumatakbo ka eh. Hindi na siya makapagdagdag. So that's called impaired systolic reserve kasi hindi siya makapunong maigi kasi ang tigas ka ng LV mo. Pag nagpupuno siya, hinihingal naman si boss kasi umaangkat nga yung pressure to the lungs. And there's also chronotropic incompetence. Ano ibig sabihin yan? Hindi siya makapagpabilis ng tibok ng puso. No? Walang, because na inhibit ng parasympathetic and then puro sympathetic na lang. So, there's chronotropic incompetence. Probably, hindi lang masabi kung bakit. Sabi na baka daw sa impaired ng vagus or so forth and so on. But what they found out that there's, pag humihingi ng more blood, hindi kaya ng volume, so dadaanin sa mas maraming tibok, hindi siya hindi siya makapag-increase ng heart rate. And of course, there's renal dysfunction and neurohumoral activation, the renin-angiotensin-aldosterone system. There's an increase in the reabsorption of sodium and water. Kaya lalong ma-overload ang puso mo. There's impaired ventricular vascular coupling. Kasi dapat, pag sinabi maganda ang ventricular vascular coupling, malambot yung LV mo, nagbabasodilate yung periphery para pagbomba ng LV mo, accepting yung vascular system, yung aorta and arteries. Pero when that sa HFpEF, wala, ang tigas ng puso mo, ang tigas din ng ugat mo. So it's impaired ventricular vascular coupling reserve. And then there's subtle resting contractile dysfunction. Mamaya pag-uusapan natin yan. Ngayon lang yan, bago lang ito. And then there's resting, systemic and pulmonary vascular dysfunction. So talagang mataas ang pressures because of kasi tandaan nyo, ang heart ang sentro ng circulation. Kaya pag tumaas ang pressure sa lungs, lahat yan apektado, whether systemic and pulmonary vascular. So actually, ang hemodynamics is at the beginning pa lang, nakaupo pa lang yung pasyente, mataas na yung kanilang LV, diastolic filling time. Counting stimulus lang, konting asin lang, konting pagod lang, konting pininom lang ng gamot sa rayuma, ng NSAIDs, o nag-steroid kasi nag-allergy, kaagad yun sasampa sa mataas and overcoming the pressures and causing an acute decompensated heart failure. So when kita nyo dito in the heart failure related event rates. Okay, sorry. So what are the goals in therapy in heart failure? So ito yung aking tatlong pew. The first pew is pigilan natin. So dapat new onset diabetes, gagalingan na dapat ng diabetes specialist katulad ninyo. Yung pag-control, yung pag-aalaga, and then treat all risk factors. Parang gagayahin natin yung, ano nga ba yung study na yun? Nakakalimutan ko na. Yung multi-factor control, Steno. Yeah, Steno 2 study. Dapat ganun ka talaga mag-alaga ng pasyente. Lahat ng comorbidities ng pasyente yung tatapusin mo lahat. Treat to target ng hypertension, treat to target ng cholesterol level, treat to target ng weight, tell the patient to stop smoking, and so forth and so on. So ganun. You should prevent heart failure from developing. That is the first goal. Kasi pag nagsimula na yan, wala na. Para na siyang waterfalls. Next pew is reduce death and hospitalization. Ito, marami akong pasyente na yung heart failure. I will tell you guys, halos every other month, lalo na yung advance na, halos every other month or every 3 months. So 3 to 4 times a year, nako-confine sila. Kaya madalas ako, hindi na ako sumisingil, naaawa na ako eh. Kasi naubos na ang gamot sa kapapag po ospital. Parang addict na sila sa furosemide. And so forth and so on. So talagang ubos na. And you want to reduce hospitalization. You want them to, gusto mo makatipid din sila. Bakit? Sana naman yung perang gagastos nila sa ospital, may-date naman si Mrs. Kahit sa Jollibee lang. Silang dalawang mag-asawa. Kailangan natin lahat yun. O maipasyal naman yung mga bata. O makabili siya ng bagong sapatos naman. Pero hindi magagawa yun kasi nag-iipon siya for his next hospitalization. We want to extend his life because this patient is at risk for 50-50 siya in 5 years. Kaya kailangan targetin natin lahat ng mabalitaan mong therapies, gagamitin mo talaga because you want to help the guy. And last pew is you want to improve his quality of life. Yes, hindi ko man madagdagan ng maraming taon ng kanyang buhay, I want to make sure, and I know you guys, kilala ko kayo, mababait kayong tao, si Marcy, bait-bait. I know you guys, no? Hindi mo man madugtungan ng maraming taon pa ang buhay niya, at least maging comfortable naman siya at maganda ang quality of life niya. Kaya pag may nababalita akong mga bagong gamot, talagang ginagrab ko agad, inaaral ko and everything. These are the goals of therapy in heart failure. Unfortunately, or fortunately, I don't know which one. Kita niyo yung red dots. Yung red dots are HFrEF. Pababa na siya. Ang tendency, ang trend ngayong last few years ito. Why? Because of our advances sa ating medical therapy. Bagong diuretics, meron tayong ARNI, And then, of course, meron pang SGLT2. So, dumadami na ang mga innovative drugs na nagagamit natin for HFrEF. Unfortunately, yung blue na dots, pataas siya. Pataas kasi wala pa tayong nadi-discover na magandang gamot on the way pa lang sa HFpEF. So ano ba ang contributing factors sa epidemiologic trends ng HFpEF? Well, of course, una, tumatanda na ang population. Kapag mas mahaba ng buhay, mas matigas mga puso nila because so many comorbidities. And then there's of course the increased prevalence of cardiac and non-cardiac comorbidities. Nakita niyo yung latest Philippine survey, lahat nag-uptick ngayong COVID. No? Ang hypertension tumaas ng 2.3%. Alam niyo anong pinakamataas ng uptick? Ang diabetes. 6.8% ang uptick ng diabetes ngayong COVID pandemic. And that's very scary. Kasi dumadami ang pool ng pasyente mo mag-either mag-HFrEF o mag-HFpEF. Pero alam niyo, bago sila mag-HFrEF, HFpEF muna. Alam niyo ba kung bakit dumarating kay Dr. Villela ang mga pasyente may diabetes? Yung mga pasyente niyo, bakit nakakarating sa akin? Kasi yung symptoms sila, shortness of breath, easy fatigability. Sa Tagalog, Dok, hinahapo ho ako, hinihingal ho ako. Hinihingal sila kasi ang taas ng LV pressure. So, yung mga pasyente may diabetes, ang unang-una, bago mag-HFrEF, mag-HFpEF muna. Titigas muna ang kanilang mga LV, causing shortness of breath and easy fatigability. And of course, isa sa mga dahilan kung bakit dumadami na ngayon yung HFpEFs, improve recognition of HFpEF in clinical practice. Naka-develop na ang cardiologists ng mga tools to really diagnose beyond reasonable doubt ang HFpEF. Ito pa isang dahilan kung bakit dumadami ang heart failure sa ating bayan o sa buong mundo. Yung elephant in the room. The elephant in the room is called obesity. Nung tinignan namin yung relation ng weight sa cumulative incidence of heart failure, nakita namin na yung mga obese, sila yung pinakamataas ang incidence ng heart failure. And we soon realized na hindi pala ang obesity, hindi lang pala heart failure. Siya ay lung disease din, liver disease din, as a snaffle, so lungs, chest wall restriction, visceral adiposity, nagiging yung kanyang tiyan, nagiging factory ng pro-inflammatory cytokines and chemokines, yung kidneys siya, tumataas yung dysfunction, skeletal muscles na nag-hypoperfusion, and of course, the effects sa heart. So, hindi lang heart ang biktima ng obesity. Bukod doon, nagkataon ba? Ewan kung bakit. Kasi pag matanda ka na, bumabago lang yung metabolism. The aging system, the aging factor is ay sumasabay sa pagtaba ng mga tao. Mataas na yung blood pressure, kaya nag-remodel yung LV niya, and then hindi siya maka-exercise kasi masakit na yung mga buto-buto, may rheuma, no? Tapos, there's ventricular and vascular stiffening. Matigas na ang kanilang LV, kaya konting hindi na maka-jog kasi pag nag-jog, hingal na, wala 10 seconds pa lang, hingal na. And of course, yung effect ng obesity and metabolic stress causing a global loss of cardiac, vascular, and peripheral reserve. Yung datang pinakita ko sa inyo kanina. And ang endpoint yan is HFpEF. Yan ang umpisa. So in short, HFpEF is cardiometabolic syndrome to the max. Nakita namin ang connect ng obesity, insulin resistance sa HFpEF. It's causing obesity and insulin resistance, and diabetes, of course, causes abnormal cardiac mechanics, which is not visible to the naked eye. Ano ibig sabihin to, not visible to the naked eye? Pag pina-2D echo mo, di ba, siyempre pupunta sa inyo, yung mga pasyente niyo may diabetes, sabi niya, Dok, hinihingal ho ako. Siyempre, sabi mo, sige, magpa-2D echo ka. Pagbalik ng pasyente may 2D echo result, normal. Wala ka naman sakit sa puso. Baka naman sinungaling ka o baka dahil mataba ka o dahil baka matanda ka na. Yun sasabihin mo. Pero huwag yung sasabihin ganun. Because the abnormal cardiac mechanics is not visible to the naked eye, to the transthoracic Not even to the esophageal echo. Hindi siya nakikita. Sorry. Ano yung sabihin ng abnormal cardiac mechanics? Ito yung puso, di ba? Di ba pag kumakain ka ng meat, may ano yan, may hibla, may grain. Sa pag-steak nga is, ano ba, do you cut across the grain o do you cut along the grain? Ganyan yung pinag-uusapan pa natin ngayon pag kumakain tayo ng steak. Yung grain na yon, yun yung direction, insertions ng fibers ng puso. Like ito yung aking picture sa kaliwa. So hindi naman ang contract ng puso, hindi naman ganyan eh. Hindi siya ganyan. Kasi depende sa saan ang direksyon. Saan ang direksyon ng fiber ng myocardium. So hindi siya ganyan. Kasi papaganyan siya. Pa-twist. At nakikita lang yan sa 2D speckle tracking echocardiography. Hindi pala ganyan ang tibok ng puso natin. Kapag ganun, pa-twist, parang pinipigang ganun. Kasi because of the direction of the fiber of the myocardium. So ito yun, sinasabi ko, LV twist, apical rotation, basal rotation, pagka-opposite, parang pinipiga ang puso. Tatlo ang direction nila, circumferential, longitudinal, at radial. Oh, yung circumferential, so it's papaganyan. Ganyan. Yung radial, tinignan ko ngayon, ano ba difference ng circumferential at radial? Yung circumferential, papagano ang movement. Yung radial, palabas. Pag gano'n ang movement. Itong longitudinal, ito yung paigsi. Kaya kung itong element mo, paigsi siya, yung longitudinal. Depende sa direction ng fiber ng cardiomyocyte. So it's an LV twist. Hindi siya ganyan. Ngayon lang na-discover yan. No? Kasi ang akala natin ganyan lang siya, ganyan. Parang baby, close open. Hindi pala ganon. It's a twist. Gumagana ng puso natin. At nakita nila, ang una-una nangyayari is there's a reduction in the longitudinal movement ng puso. Yung ganon. Yung pag-iksi, di ba pag nagko-contract, dapat longitudinal, pahaba, dapat i-iksi. Bumababa nababawasan ng pag-iksi. So ang tawag doon, global longitudinal strain. Nababawasan yung strain, yung movement, yung motion, yung deformation ng muscles longitudinal. Dapat ganyan eh. Yung sa kanila, nababawasan. So, tingnan, the natural history of temporal evolution of myocardial mechanics. Sa stage A, during the time na diabetic pala yung mga pasyente nyo, na may hypertension pa lang, no? May CKD o obese, doon kisimula na ang left ventricular global longitudinal strain. Umiiksi na yung movement, yung motion ng longitudinal contraction. So sa stage B, magko-compensate ang puso mo kaya may structural defects siya. Kaya mag-LVH siya and everything to overcome the strain, no? To overcome the stress na nangyayari sa contraction. So papakapalin niya yung muscle niya. So kaya tingnan, dire-diretso yung pero by the time na hindi niya na kaya mag-compensate, magsisymptomas na yung pasyente sa stage C. And by the time na stage D na, yung progressive advanced heart failure na, ando na yung fibrosis, LVH, and cellular dysfunction. So nakita na ito palang mga itong global longitudinal strain, nagsisimula ng maaga. So anong importansya nito sa atin? Sinasabi ko lang sa inyo, the diabetologists or the diabetes specialist and the heart specialist should work together. Dapat magka-team tayo dito. Pagsasaluhan natin itong pag-control niya. Because kita nyo, dire-diretso pala siya. No? This strain pattern is the start of worse heart failure events. At nakita lang itong global longitudinal strain, it predicts mortal and morbid events. So pag may pasyente kang diabetes pa lang, pina-echo mo, normal, subukan mong pa speckle tracking siya, speckle tracking. Pag ang report ng speckle tracking ay global longitudinal strain abnormality, ibig sabihin, yung pasyente is a very high risk patient for death or morbidity. So, dito nakita, ano ang relasyon ng obesity, insulin resistance sa cardiac mechanics? No? Nakita na the bigger the body mass index, the higher the fasting glucose, and the more the insulin resistance, mas pumapangit ang global longitudinal strain. Kaya yun. So, obesity and metabolic syndrome are potential targets for HFpEF prevention and treatment. Kaya, pagsamahin natin, pag may pasyente kang obese at may metabolic syndrome, kailangang papayatin natin. No? Ibilhan mo siya ng Doberman, tapos pahahabol mo siya sa Doberman tuwing umaga para tumakbo siya. So, diet and exercise work in patients with HFpEF. Look at this graph. Against control, diet and exercise, change in peak activity, and feeling good. No? Kansas City cardiomyopathy score, nag-improve. No? The more they exercise and the more they go on a diet, mas nag-improve ang kanilang quality of life. Let's go to diabetes and heart failure. Of course, we all know now diabetes is a key risk factor for heart failure. It is stage A condition. A large proportion of type 2 diabetes patients develop structural heart abnormalities. So pag nag-LVH siya, stage B na yun. So pag may pasyente kang diabetic, tapos pina-echo o pina-ECG mo, ang tingin mo sa ECG, LVH, stage B heart failure yun. So kailangan sabay tayo. Ayusin mo yan, boss. Leading to symptomatic heart failure stage C. Multiple mechanisms in type 2 diabetes responsible for heart failure progression. Maraming mekanismo. Of course, alam yan. Pero it can be lumped into a thing called inflammation. Once heart failure ensues, prognosis is poor. Pag nag-stage C, dire-diretso yan sa class 2, class 3. Prevention is critical. And anti-diabetic agents vary substantially in terms of heart failure outcomes. So, sad to say, SUs and biguanides, they have no effect on heart failure outcomes. Lately, the SGLT2, sila yung nakita sa HFrEF. May mga ginagawa pa silang evidence sa HFpEF. Ang GLP-1 receptor agonists, well, ano sila? Modest effect sa heart failure with big effect sa control of atherosclerosis. So, yun. Yung mga pasyenteng may diabetes na maaga pa, in-examine sila sa New Zealand. It's called the Zealand study. 605 type 2 diabetes, age more than 60, primary care. Ibig sabihin, wala pa silang complication. So pinagsama-sama yung symptoms, signs, echo, and adjudication, meaning in-examine ni doktor kung ano man nangyayari sa pasyenteng ito. They saw 2.5% ng mga pasyenteng yan are diagnosed to have heart failure. 4.9 have reduced ejection fraction, pero 22.5%, so 1 in 5 patients na may diabetes have HFpEF. And imagine what lahat ng nangyayari sa pinag-usapan natin kanina, nangyayari sa pasyenteng yan. And prevalence of structural abnormalities in type 2 diabetes, ang dami. Halos kalahati siya have LV hypertrophy, LV dilatation, historic dysfunction, and hypokinesia. This is stage B. No? So yung pasyente mo, Elwin, hindi siya diabetes lang. Siya ay heart failure stage B patient. Because of course, I know you know this, pasensya na. So because of the impaired glucose handling and insulin resistance causes a storm of oxidative stress, causing inflammation, which causes fibrosis, decreasing compliance, and pag na-decreasing compliance, diastolic dysfunction. Later on, systolic dysfunction, then you have diabetic heart failure. Ako, ang dami ko niyan. Ang dami ko niyan, Marcy. Diabetic heart failure, ang dami ko niyan. As in, nakakaawa talaga. So, mas madalas ang balik nila sa akin for check-up. And then, of course, inflammation causes vascular endothelial dysfunction causing hypertension. Pag may high blood pa, ay lalong lalaki ang kanyang LV, lalong mag-hypertrophy. And then atherosclerosis, babarahan yung mga coronary arteries, bababa ang perfusion. So ang tawag doon, ischemia, and then coronary artery disease causing all these things. Ito yung diagnosis na ginagamit natin. So una, ito kasi sinulat ito 3 years ago. Kay Bronwald ko ito kinuha sa aming Bible namin. Clinical evidence of heart failure. So dapat may clinical presentation ka ng heart failure. So how to diagnose? Ito muna, clinical presentation of heart failure. Yung pinag-usapan natin kanina. Itong Framingham criteria or Boston criteria, hindi na yung sinusunod. Sinusunod na natin 2021 universal definition. Okay. And then supportive corroboration, corroborated by increase in BNP or NT-proBNP, chest X-ray ng pulmonary congestion. No? Okay. And then, papa-2D echo mo. Pag ang ejection fraction is more than 50%, HEPF yan. Pag ang kanyang ejection fraction is less than 40%, HEFREF. Gitna, mild reduced heart failure ang tawag doon. And then, huwag niyong kakalimutan to manage the comorbid disease. You should treat to target, no? Ano ang target ng hypertension sa diabetic patients? Less than 130. Okay? You should treat diabetes, you should treat ito advanced age. Wala kang magagawa talaga dyan. Siguro you should take care of the nutrition of these patients. AF, managing AF, chronic kidney disease, yung manage mo. So, ibig sabihin, bukod sa binamanage mo na yung kanyang puso, ma-manage mo rin yung kanyang comorbid diseases. Itong sa baba, itong sa letter D, letter E, sa echo na yan. Pero ito, bago ito, ginagamit ito sa Mayo Clinic. The HEP2-PEF score. This is a tool to distinguish HEPF from non-cardiac causes of dyspnea. Paano malalaman yung hinihigale hindi sa COPD niya? At dahil sa kanyang HEPF, dahil sa mataas ang LV systolic function. Ang mataas ang kanyang feeling pressure. So, ito yung kanilang suggestion. So, HEPF, HEF2PEF. H2 kasi dalawa, kasi heavy pag mataba, choy, meaning obese, no? More than 30. Heavy and hypertensive. So, kung mataba siya, may high blood siya, H2 na yon. Fibrillation, ang F. P is pulmonary hypertension. Bakit nga ba tataas ang pressure sa pulmonary? Kasi nga natatransmit yung LV and diastolic pressure to the LA, and then to the pulmonary veins, then to the pulmonary capillaries. Kaya tataas ang pulmonary artery pressure. Okay. And then L there, meaning H60, and then feeling pressure sa echo. Usually E over E prime is more than 9. Tingnan nyo na lang yung sa tingnan nyo lang yung sa report ng 2D echo. When you have, pag na-add mo yung mga yan, ito yung mga interpretation. 0 to 1, unlikely. No? 2 to 5, dagdag mo pa ng examination. Pag 6 to 9, malamang-lamang HEPF nga yung kalaban mo. So the role of, pero in the end, 2D echo pa rin ang ginagamit para ma-diagnose ang HEPF. Sorry. Heart failure with preserved ejection fraction. Una, if the ejection fraction is more than 50 at hinihingal, namamanas, HEPF yan. And then, corroborated by LVH. Tapos malaki ang kanyang left atrium, dilated. Tapos meron kang regional wall motion abnormalities. Tapos meron kang, ang report ng echo niya is diastolic dysfunction. There you go. Voila. HEPF ang pasyente ko. So, considerations for use of BNP or NTP or BNP sa HEPF. Kung minsan sa HEPF, hindi tumataas ang NT-proBNP or BNP. Bakit? Kasi ang natriuretic peptides, nare-release yan sa degree ng stretch ng left atrium. Nagaling sa stretch ng left ventricle. Tingnan nyo na lang to. Sino mas malaking stretch ito sa picture ko? Sino mas malaki yung stretch itong sa hypertrophy, which is diastolic heart failure, or dito sa dilated heart, which is systolic heart failure? Siyempre dito sa systolic, mas mataas yung stretch dyan. Kaya mas mataas lagi ang NT-proBNP o ang BNP ng HFrEF kaysa sa HFpEF. Kaya mahirap din siyang basta-basta paggamitin sa diagnosis. Kasi sometimes 30% ng natriuretic peptides sa mga HFpEF ay normal. Okay. Kasi nakita dito na ang BNP mas mataas ang systolic heart failure kaysa sa diastolic pressure, and diastolic wall stress, yung banat, yung stretch ng myocardium, mas mataas sa systolic heart failure than sa diastolic heart failure. And they saw that the lower or the higher the end diastolic wall stress, the higher the BNP or the lower the BNP. Treatments. So dito sa kanan, yung kulay blue, nakita lang ang daming patok, ang daming evidence na ang mga ARBs, ACE inhibitors, digitalis, beta blockers, ACE, saka beta blockers, they all improve or reduce death and heart failure hospitalization sa mga pasyenteng merong HFrEF. Pero sa HFpEF, tingnan yung mga studies, lahat nakatuntong dito sa forest plot na ito, nakatuntong lahat sa line of neutrality. Hindi sila nagpakita ng improvement sa iPreserve, sa itong dalang iPreserve, tsaka itong CHARM, ARB, itong PE-PEF-CHEF, ano to, ACE inhibitor, Preserve, this is digitalis, and so forth and so on. Walang nag-positive. Lahat nakatuntong sa line of neutrality. They did not improve the patient. Prior outcome trials sa HFpEF, sa CHARM preservative, ginamit ng candesartan, wala. Look at the p-value, 0.5. Sa iPreserve, gumamit ng irbesartan, walang nangyari. Okay? Sa PEF heart failure, perindopril, walang nangyari, hindi na-improve. Sa top cut yun, merong konti, may modest improvement ng outcomes. Ang top cut kasi ginamit siya ng spironolactone diuretic. Tapos, HFpEF sa seniors trial, ginamit ng nebivolol, sabi, significantly reduce all-cause mortality. Pero teka muna, don't jump agad. Tinan nyo muna yung population yan. Ang ejection fraction is 35%. So, hindi yan HFpEF. No? HFrEF yan eh. Kaya nag-improve with beta blockers. Dito sa candesartan, talagang negative. Look at the p-value, 0.5. Sa Paragon naman, nakita lang sa Paragon trial, which used the RNA, nakita lang na kapag ang ejection fraction is less than 57, nag-improve. Pero if the ejection fraction is 57 and above, meaning normal, walang effect. It did not improve. So may konting liwanag, no, ng ilaw sa RNA with regards HFpEF. So this is the guidelines, HFpEF guidelines. Now sa American, sabi ng mga Amerikano, diuretics should be used to alleviate symptoms due to volume overload. Class 1, so ang taas ng recommendation. Use beta blockers, ACE inhibitors, and ARBs if hypertensive yung pasyente. Class 2A. So, mataas-taas na rin yan. As may enough randomized controlled trials. Tapos, yung third statement is ARBs might be considered to decrease hospitalization. Kasi sa heart failure po, ang gold standard talaga is ACE inhibitors. Pag hindi lang makatolerate ng ACE inhibitors, saka ka mag-ARB. Pero ngayon, yung latest, yung 2021 guidelines, no, ang sinasabi nila is, wag ng ACE o ARB, RNA na ang gagamitin nyo as first line, sabi ng guidelines. And then, sa yung mga Europeans naman, sabi nila, diuretics are recommended in congested patients with HFpEF and mildly reduced ejection fraction, yung 40 to 49, in order to alleviate symptoms. Class 1. Pero ito, alleviate symptoms lang ito. Hindi improve mortality and hospitalization. So, quality of life. So, ginamitan yung mga pasyente may HFpEF sa study nito sa chlorthalidone, which is a diuretic, of course you know that, hydrochlorothiazide. So, which is kapatid ng chlorthalidone. Mas mababa siya as compared to lisinopril, no? And then it's a preserved ejection fraction. And reduced ejection fraction, well, it's better, no? So, ibig sabihin, ang diuretic talaga nakakatulong sa mga pasyente may heart failure. Spironolactone, ito yung sinasabi ko kanina na preventive effect on heart failure hospitalization. Hindi nila naibaba yung mortality, pero naibaba nila yung yung ma-hospital ka, mababawasan pag nag-maintain ka ng spironolactone, magmamonitor ka lang ng potassium as compared to placebo. So where are we now? Sa treatment ng HepPef, we're in between a rock and a hard place. We're in between a rock and a hard place. Wala tayong mapuntahang maganda-ganda. Pero current management recommendations sa HepPef, 1, consider alternative diagnosis. 2, symptomatic treatment with diuretics. 3, treat mo ang hypertension, treat to target. 4, treat mo yung other comorbidities like obesity, like smoking, like diabetes. No? 5, rate control. Kung di mo siya ma-convert sa sinus rhythm, kontrolin mo yung bilis ng heart rate. Kasi the faster the heart rate, the shorter the diastolic filling time, lalong mag-heart failure yung pasyente. 2, 4, 6, 6. Treat ischemia. Kasi pag may ischemia ka, predisposed sa more heart failure. And questionable is spironolactone. Kasi dapat may mas malaking study pa na nagpo-proclaim talaga na talagang spironolactone is it, the drug for HepPef. So there are 2 ongoing trials, HepPef trials with SGLT2 inhibitors, yung Emperor Preserved na ginamitan ng empagliflozin, and of course, yung ating sponsor ngayong gabi, ang Beringer, no? Ano ba yan? Beringer or Boehringer. The DELIVER study, they used dapagliflozin among patients with heart failure. Wala pa pong resulta. The jury is still out. Hindi pa yata tapos. So, hinihintay natin ang effect nitong dalawang ito. So, conclusions. HepPef currently accounts for approximately half of heart failure cases, but is increasing in prevalence. The risk of mortality in HepPef and HFrEF is comparably high, but mortality in HepPef is more likely to be influenced by comorbid conditions. Patients with HepPef have impaired quality of life, limited functional capacity. Large clinical trials of heart failure therapies have been largely neutral pagdating sa HepPef. Comorbid conditions drive systemic inflammation that ultimately contributes to myocardial remodeling in HepPef. SGLT2 inhibitors, baka pwede silang maging sagot. Sabay-bayan ang susunod na kabanata. In the end, alam ko naghahanap tayo lahat ng evidence for management ng HepPef. Pero wala pa sa ngayon eh. Sabi nga, we sometimes do fly by the seat of our pants. Ang ibig sabihin niyan, better yung sa ating instinct, intuition, yung ating judgment ang ginagamit natin. So walang guidelines eh. But ito yung question ko sa inyo, ang parachutes ba may guidelines? Parachutes reduce the risk of injury, but their effectiveness has not been proven in randomized clinical trials. So for now, use your better judgment. Ang pinakamagandang kakampi natin dito ay diuretics and spironolactone. So, marami na akong nasabi, kayo naman. Maraming salamat po.
Thank you, thank you. Let's have a round of virtual applause kay Dr. Belela. It was really an excellent, he is really always an excellent speaker. Kaya sir, panayang invitation nyo. So now we open the floor for your questions. So meron pong isang question dito with Dr. Danny Baltimore. No, sabi niya po, if we manage to control the diabetes of patient with HFrEF, reversible, is it reversible?
Sa HFrEF hindi nakita eh. Pag HFrEF, no matter what you do, ito nga nakakataka eh, 'di ba? Ang HFrEF, ang heart failure with reduced ejection fraction, is directly correlated with an increase in HbA1c. Pero nung target taling HbA1c, ibinagsak nila, they were expecting na bababa yung HFrEF. Hindi eh. Kaya nga it's nakakabulabog. Sa HepPef, wala pang balita.
Mm-hmm. So one of another so natagot niyo na po ito, yung preserve evolved to become reduce. So sinagot niyo na po further in your in your lectures na mag-iumpisa muna as preserve, then at the end, at the stage D, yun ng reduce, no, with Dr. Caridad Hipolito. Another question from Dr. Caridad Hipolito. Almost always in our hypertensive and diabetic patients, there's 2D echo show grade 1 diastolic dysfunction. What is the significance of this? You mentioned treat all comorbidities optimally. Is there any medication to address this?
Oo. So, ako, although wala pang guidelines, now I'm flying on the seat of my seat. On the fly of my seat. So, ito'y better judgment lang ito. Nakapapansin ko, yung mga pasyenteng nagpupunta sa akin na may diabetes, kaya nakakarating sila sa akin, shortness of breath lagi. Dok, parang hinahabol ko hininga ko. Yung iba naman, Dok, na isang araw nagkikwento ako nag-dinner kami, nagkikwento ako, sabi ng mga anak ko, Pa, ba't pa hinahabol ang hininga mo? Hindi ko naman napapansin, sabi niya. Isa naman, kausap niya yung misis niya sa telepono. Sabi nung kanya misis, Love, bakit hinahabol mo hininga mo? Hindi niya napapansin. You know why? Diastolic dysfunction. Tumataas ang pressure. Kaya you know what I do when I see those? Spironolactone. In probably 75% of cases ay nag-i-improve ang pasyente. In 25%, siguro kailang i-push ko pa. So yun. Talagang diuretics. Yung diastolic dysfunction, that's it. Yun yung kasabing grade 1 diastolic dysfunction, yun na yung umpisa. Ang aking suggestion, wag na nating palalain. Kaya bakit maganda ang spironolactone? Hindi siya diuretic talaga eh. Di ba napakahina ng diuretic effect ng spironolactone? Pero ano siya? Anti-aldosterone, anti-fibrosis. So pinipigil niya mag-deposit yung collagen at fibrin sa ating LV. Kaya hindi siya titigas talaga masyado. Kaya wag yung tanggalin. Monitor yung spironolactone. Monitor nyo lang yung potassium kasi siyempre baka mag-hyper K. As long as the creatinine is okay, as long as ang kanyang baseline potassium is 5, pwede kayo magbigay ng spironolactone. Basta every month lang or every 2 weeks meron siyang potassium determination.
So meron din po ditong another question from Dr. Faye de los another question from Dr. Faye de los Santos. Will trimetazidine or ranolazine help in the treatment of preserve?
Ako tingin ko yes. Pero alam mo, Marcy, since nasa lecture forum tayo, dapat yung lecture nagsasalita ng based on evidence. Walang ebidensya kasi, ma'am eh. Walang ebidensya. Pero kung titingnan mo yung logic ng trimetazidine tsaka ng ranolazine, baka pwede. Tsaka sabi naman ng guidelines, treat all comorbidities. Kung may ischemia yung pasyente, treat mo ng ranolazine, baka mag-improve yung pasyente. Pero unfortunately, si trimetazidine tsaka si ranolazine, ayaw nilang gumawa ng studies sa heart failure. Kaya wala tayong basihan. Pero kung akong tatanungin niyo, baka pwede yun.
Okay. Thank you, sir. So a lot in the chat sa chat box po natin, lahat nagpapasalam. From Dr. Rowena Libed, thank you very much for a very well explained and clear delivery of the lecture of preserve heart failure. Dr. Toy Chua, thank you, Dr. Gilbert. Galing talaga. From Benluan, thank you very much for a very informative lecture. Then, sir, eto, another question from Dr. Lilia Conejos. Can we give ARNI, SGLT2, and spironolactone at the same time?
Yes po. I do that. I do that actually. Babantayan mo lang. Babantayan mo lang yung potassium. Ano ang karanasan ko? In fact, maswerte po ako. Kasama po ako doon sa Paradigm Heart Failure Trial. It is a multi-central, multi-country study. Isa po ako sa mga principal investigators. Karanasan ko, hindi kokonti yung nag-hyper K talaga. Kokonti. Pero meron. Kaya ayokong ayaw kong palakasin ang loob nyo, ay baliwala nyo. Pag monitor kayo ng potassium, pwede silang pagsabayin.
Okay, thank you, sir. Another question from Dr. Ray Rosales.
Right.
Any other diagnostic modality to detect heart failure aside from 2D echo?
Well, kaya 2D echo ang favorite kasi unang-una, napakapalasak na siya. Halos lahat ng ospital may echo. Number 2, hindi na siya masyadong mahal ngayon. Unlike nung una. Alam mo, Ray, ang tatandaan ko na, yung panahon pa ni Dr. Mobono Calleja, ni Dr. Ramon Barquez, nung panahon nagte-training pa ako, naku, mahalata ang age ko. Nag-caliper pa ang pinasusukat namin sa ejection fraction eh. Sa M-mode. M-mode pa kami na. At ang mahal-mahal pa noon ng 2D echo. Pero ngayon talagang so para na siyang ECG. MRI, pwede. Kaya lang mas mahal. Tapos mas malaki ang exposure mo sa radiation. Kaya ang pinaka-practical, Ray, echo.
Pero ngayon ko lang, sir, nalinig sa inyo yung 2D speckle tracking.
Speckle
echo.
tracking, oo.
Dapat ba naming specify, sir, yung ano na yan, yung echo na yan, once we wanted to determine if our patients will have this preserved heart failure?
Well, if your patient is being so problematic, pag masyado siyang maraming complication, na normal ejection fraction, ginawa mo na lahat, controlled ang sugar, controlled ang BP, the patient, pumayat na siya ng 10 pounds, tapos, pero hingal na hingal pa rin siya, pwede kayo mag-speckle tracking para lang malaman mo. So, i-specify mo. Yung speckle tracking, it's computer analysis. So, meron silang mga, parang masyado siyang high-tech. Hindi ko maipaliwanag kasi hindi ako echocardiographer. Pero I've read about it at nakikita ko yung mga kasama ko sa heart center na nagme-measure yan pag nakatambay ako sa non-diagnostic laboratory. It's computer-based. So may app na ginagamit talaga pang measure. Minamarkahan nila yung mga points sa left ventricle para titingnan kung gaano kalaki yung igsi, yung deformation. And they can measure, and then depende sa measurement, masasabi lang, naku, high risk ng pasyente o kaya, okay pa to. Ganon, masasabi nila yon. So when your patient is highly problematic and you think this patient is high risk, pwede kayo mag-request. So, ang request is 2D, two-dimensional speckle tracking echocardiography.
Okay, sir. So, another question, sir. Napakadaming question, sir.
Yeah, go ahead.
Rafi Cruz, no? Kasi ngayon lang nila nadinig na sinabi nyo na can we use Entresto to pre-heart failure? Kasi parang nabanggit nyo, sir, yun. Can we use Entresto to pre-heart failure?
Actually, may mga study ngayon na ginagamit na ang Entresto is ginagamit nila sa hypertension na. Wala pa yung heart failure. Kaya lang wala pa akong resulta.
Ako yan.
Kaya hindi ko alam kung anong makikita nila doon. So, ang question nila doon is, can Entresto be used to treat hypertension among patients without heart failure? Wala pang resulta. So, subaybayan ang susunod na kabanata. Yung experience natin ng Entresto sa HepPef, negative yung study last December eh. Ano ba yung ESC? Early this year. Negative yung trial eh. So, hihintayin ko lang na himay-himay nila, islice nila yung results para lang mabasa ko. Sa ngayon, katakataka, walang lumalabas na information about yung bakit tech-fail, bakit neutral, walang effect ang Entresto sa HepPef. Pero, isipin mo yung pathophysiology, dapat meron eh, pero wala eh. So, hinihintay ko pa yung himay nila.
So, another, sir, from Dr. Antonio David. What do you suggest in patient with grade 1 diastolic dysfunction with an ejection fraction of 65%? ECG reveals LVH. Yan po yung kanyang...
So, isipin nyo so LVH, malalaki yung kanyang cardiomyocytes. So, pag lumaki ang cardiomyocytes, kung ganyan kalaki yung LV niya, lumaki yung wall, liliit yung lumen. Tataas ang pressure doon. So yung unang symptoms ng pasyente mo, shortness of breath, So hindi maganda ang kanyang quality of life. Kung minsan sasabihin niya, kumusta ho kayo Mr. Reyes? Okay po naman ako. Nakakapasyal ba kayo? Hindi ako makapasyal dito, hinihingal ho ako. So see, akala ko ba okay siya pero yun pala, nililimit niya yung kanyang sariling physical activity because hinihingal siya because of the diastolic dysfunction. Kahit na ang kanyang ejection fraction is 60, I think, no, spironolactone can help. Kasi by the time na bababa na yon, marami na nakadeposit ng collagen doon. Tandaan nyo, ang spironolactone is not really a diuretic. Palagay ko, ang effect niya is a little diuretic, pero more of anti-collagen deposition. Para hindi tumigas ang puso ng pasyente. I think I would do that. Pero siguro hindi sa lahat. Dapat yung symptomatic talaga. David.
Okay, sir. With Dr. Agnes Soriano, no? When you are looking on the results of 9F2D echo as a general internist, what are the parameters you need to look at aside from ejection fraction?
Thank you. Salamat. So, usually, ang unang mantitingnan, yung unang numbers sa kaliwa o sa yung report, yung left ventricular end diastolic diameter. May range yun 4.5 to 5.5. So makikita mo, pag HFrEF, reduced ejection fraction, lagpas siya ng 5.5, mga 5.7 or 6. Oh. Pero pag HFrEF, normal yung LV size. So yung LV size, LV dimension. And then, susunod doon is yung mahirap interpretin yung numbers, basahin na lang, tingnan yung interpretation. Basahin yung interpretation. Pag nakakita kayo ng grade 1 diastolic dysfunction, there you have it. Matigas ang LV, transmitted to the LA, and then LA to pulmonary veins, then pulmonary capillaries, kaya shortest breath ng pasyente. Matigas ang puso. Bukod sa malaki at makapal ang puso, matigas ang puso. So you better do something about it. Number 1, weight reduction. Diba? Number 2, exercise and diet yan. Number 2, spironolactone probably. Number 3, treat all comorbid conditions. Treat to target. Kahit na ang treat to target sa diabetes walang evidence, wala nang masama kung hindi mo i-treat to target. Bakit? Kasi ang diabetes, tatay pa ng more hypertension, tatay pa ng more inflammation, tatay pa ng more collagen. Kaya kahit sabihin nilang, wala namang correlation ng HbA1c sa HFpEF, i-treat mo na din to target. Kasi walang mawawala, everything to gain. Kasi hindi nakikita yung connect indirectly. So, pa-stop mo smoking, pa-reduce mo ng weight, blood pressure is very important, no? 130, kung below pag below 65, target BP is 130/80. Pag matanda na, mga 75, 80, 140 ang target pababa. So medyo lenient ka. Sa ngayon, yun pa lang ang stand. Hindi pa naiiba kung ang isang heart failure patient ba dapat mas mababa ang target BP. Wala pa. Sabi nila basta ibaba mo ng 140. Pero tingnan nyo bihirang-bihira ang pasyente may heart failure rather than reduced ejection fraction na high blood. Bakit? Ano bang formula ng blood pressure? Cardiac output times peripheral resistance. Pag may heart failure ka, reduce ang cardiac output So, halos impossible na tumaas ang BP. Pero pag mataas ang BP ng pasyenteng may heart failure with reduced ejection fraction, isipin nyo, vasoconstriction yan. Nako-constrict kaya mataas ang BP. So, ACE inhibitor ang first choice or an RNA or an ARB. So, yun.
So, siguro isa na lang pong question, although a lot of question pa, pero isa na lang pang entertainin natin kasi it's almost 8 o'clock. Sabi po dito, what level of ejection fraction kay Dr. Danny pwede po na ma-advise ang exercise?
Any level. Yung exercise is graduated yan. Depende sa status ng kanyang cardiovascular system. So, In fact, yung sa heart failure with reduced ejection fraction, yung mga 28 ejection fraction, 30 ejection fraction, in-exercise namin yan. Pero siyempre, graduated. Tapos, ang pinakamaganda niyan, Danny, refer mo sa isang cardio na cardiac rehab specialist. Nung ako fellow, yan ang paper ko eh. Hindi pa uso nun yung cardiac rehab, yung exercise sa mga pasyenteng dilated cardiomyopathy, yung heart failure with very low ejection fraction. Yan ang paper ko. Alam mo, sa sobrang bago yung paper ko, nakapunta ako ng Puerto Rico, na-present ko yan sa World Congress on Cardiac Rehabilitation. Pero ngayon, palasak na yan. So, walang level, at any level of ejection fraction, you can ask the patient to do physical exercises. Pero it would be better and safer kung siya ay managed ng isang cardiac rehab specialist.
Mhm. So in line with that, sir, may
Kami pang question.
Julina Santos, sabi niya, last should our patient be subjected to stress testing before we recommend type of exercise? Before we recommend type of exercise?
Yeah, usually ang nagre-request yan yung cardiac rehab specialist. Kasi hindi mo sila pwedeng kung sila ay heart failure with reduced ejection fraction, short of breath talaga sila. Nakakaawa naman, papa-stress mo pa. Pero merong may protocol, may protocol meaning may type of stress test that is safe for those people, no? So ako ang suggestion ko, thank you sa mga tanong na yun, ang ganda, as in nakakatuwa kasi feel niya yung aming depression sa mga pasyente may heart failure, kaya kay ganyang magtatanong. What I want you to do is to work with us, as we all love to work with you. Ako, I always work with diabetes experts like you yourselves. So, kapag may ganun kang pasyente, gusto mo siyang pa-exercise, refer mo sa cardiac rehab specialist para makatulong ka sa pasyente. Expert yung pasyente, yung doktor na yan.
So with that, thank you very much, sir. Hindi ko na babasahin. Another round of applause with Dr. Abiliela for that very nice question and answer. We have a very interesting night at napakadami nating audience na very participative with their questions, as well as very appreciative sa inyo. Napakagaling yung mag-lecture. So with that, we say thank you very much. Sana, sir, ma-invite ulit namin kayo for another topic with the PSD. Okay, sir? So,
salamat din sa boring girl.
Opo, salamat po sa boring girl, sir. Salamat po sa sponsor natin for tonight. Okay. So that we end for tonight's PSD Select. I want to remind everyone that we have the nomination has ended this 12 noon, So you will receive we will be voting for the new officers by September 1 to 15. We will send you all the final candidates. Please send in your votes to our secretary. Ni Dr. Elwin, we will be having our next PSD Select. Our topic is the complication naman ng kidney, ang ating topic next time with Dr. Froilan De Leon. It's the KidneyGo updates. So thank you very much sa lahat sa inyo. And thank you very much again to BI as well as Katay for tonight's event. And to our two wonderful speakers, Dr. Bilela and Dr.
Bugarin.
Bugarin. Thank you so much. So thank you and be safe, everyone.